you hear me? Yeah.
People on
The opportunity to, I shouldn't say opportunity, but it was an opportunity to take a look at the whole arena of sexual harassment. And so in examining sexual harassment, we ran against this issue of, well, what's going on in the government amongst its employees? How it did, let me just, yeah, thank you. How does it really affect us all? This issue of concerns about retaliation, things like that. So we went a little deeper. We started talking about the workplace security. And so here we are today. And so we decided we would ask experts to talk. And we want to record your information because we want it to be a part of the record. And so that's why we're here today. We decided, well, let's invite all of our colleagues here at the council. We're very happy to, those who are here, that you decided that you would come. Thank you very much. So without any further delay, we get to the real script and see. Be mindful that everyone's time, each speaker has 20 minutes total, including with Q&A following each presentation. So if you have any questions of a specific speaker, please ask them at that time. After the session, anyone that has follow-up questions, please feel out to today's speakers or to my colleague, Councilmember Christina Henderson's Committee of Health or our council's HR officer. And with that, I am going to, am I serving as MC? It's okay. Today, I am honored to have Dr. Anaya Bennett from DC Health, Dr. Barbara Basil from the Department of Behavioral Health, and two esteemed UDC psychology professors, Dr. Isra Razon, I hope I didn't mess it up today, and Dr. Thomas Young, to share. A little bit like this so that you can kind of face your respective audience. Okay? So yes, everyone just come on up, please. You're upstairs. Oh, all right. Okay, all right, okay. That's why we have many minds in here, so we get a real good solution.
I'm putting my computer here so it'll go through the Zooms.
Can we turn the volume? I sound very profound with the echo, but I actually.
I can also this additional echo, extra profound.
So what I was asked to do was give a few different pieces of information, starting with just how DC Health is arranged, and then going through a couple of important points from the perspective of health about this issue of wellness and mental health. So I'm going to give a foundation, and then everybody else is going to take you from there. So DC Health is broken down into 6 administrations, and those administrations really take care of the really complex mission that DC Health has. So we have the Community Health Administration, and that does many things you're familiar with. And they mostly look at the health of individuals, families, children. So they do WIC, which is food for mothers and babies. They do cancer registry to make sure that cancer patients are getting what they need. There are lots of different layers to that, but their ultimate mission is to eliminate all disparities, racial and otherwise. HRLA, our Health Regulation and Licensing Administration, does a few things also. The regulation part is, for the most part, restaurant inspection, making sure that spaces and places are healthy. So your pool, reason the pools don't wait to be opened is because they wait for us to inspect them and make sure that they're okay, and then you can go to the pool in the summer. So all of those things are done in part of that administration. The other half of that very large group is licensing of healthcare professionals and healthcare facilities. And that's everything from long-term care to clinics and various other places. So all of those get monitored on a routine basis. So we license you, but then we inspect on a schedule so that everybody is held to maintain the same standard. We have a emergency response unit called HEPRA. It's the Health Emergency Preparedness and Response Administration. When you have an emergency, it is incredibly rare for there not to be a health component. People are generally at least at risk of being hurt. That's why we called it an emergency. And so we are responsible for making sure the healthcare sector is ready. So we do drills and things with hospitals to make sure that if there was an event, that they would be ready to accept a surge of patients. We just did an extended one on a chemical spill that we imagined had happened, and how do our hospitals respond? Do they have the right equipment? That also means that if there's an emergency, we have medications for people who had to leave their house without their blood pressure pills. We have physicians and nurses who will go out and be at stations in the middle of the emergency to try to do that kind of on the ground triage. The Office of Health Equity is really one that looks across all the administrations to make sure that the services we're providing are actually aimed at ending disparities and that our processes are equitable. And CPPE, which is our data center, essentially, also has a kind of mission across. They develop all of health statistics. When someone tells you that people in the district have a certain life expectancy or that we have this amount of this particular condition, that is all coming out of that unit for the most part. That data also is used internally to decide where to put and how much to put of all of these services. I am going to figure there are questions at the end, but if I say something that's completely not understandable, please do raise your hand and I will explain a little better. So our responsibilities are in lots of different areas. So there's making sure that you're avoiding risk. Some of that is behavior. So talking to people about what they eat and do and where they go. And some of that is actually eliminating risk. So there should not be a possible infection in the restaurant that you go to. You just go to the restaurant and assume that we've made that clear, and we do. The same for environmental hazards. We are not the cleanup crew, but we are the people who should be looking at whether or not a hazard like the oil spill in Maryland. We talked quite a bit to DC Water. We talked about how it would affect fish consumption and people's consumption of fish that come out of that area. So that is our responsibility, to stay abreast of all those things, basically to make sure that there are not hazards in your environment and in your life that might make you unhealthy. But then the rest of it is really lifestyle. We have HIV, well, sorry, I missed an administration. We have HIV, hepatitis, STDs, and TB are all in one administration. Those are all illnesses that happen in somewhat distinct populations more often than they do in others. And so that administration does a very good job of really looking at the whole health of people with HIV who are in that community, people who have TB and are in homeless shelters, that kind of work to look at what the whole environment is that puts you at risk of these diseases that are, not all of them, but most of them are diseases that are happening in particular groups. That kind of hazard is really kind of a lifestyle thing for the most part. It's not a choice, but it's who you're with, what you're exposed to. That kind of hazard is also true for everybody's everyday life. What kind of food is available to you? Where are the food deserts? What parts of the city are walkable? Where are they not? Where are people exposed to violence? All of those things we monitor We sometimes put programming in place when we have money. Lots of our money comes from the federal government and has lots of prescriptions to it, but we do also have local funds that help us shape all of that to DC's particular needs. So the different functions that we do in PERLA are all about, for the most part, about making sure that we have systems in place, that most of it's healthcare licensing and professional licensing. That is all about our responsibility to make sure there is a healthcare system to serve you. So you have access in this town more than other people. We have 97% or so insurance, which is really remarkable and not common, certainly across this part of the country. But that does not mean anything if there are not facilities at high quality for you to go to. We are involved in making sure that's true. We're going to put a health services plan out shortly. Part of that plan is making sure that there are mental health services, and where are they and what kind? Do we have enough outpatient services, but not enough hospital beds? What do we have that we are using, and is it of high quality? And then where are the gaps and how do we fill them? So our strategy for all of these is to engage the community, the providers we're licensing, the facilities we're licensing, all of the community groups that do wellness work. A lot of that work is focused on people who have the least resources, but the systems are the same. So if everybody has the potential to end up in that group at some point in your life, and the systems that we use to make sure that that places are safe are really aimed at making sure that the worst things are not there, but they're also aimed at really the general public. So any questions on all of that? Because I'm going to shift topics. Okay. So one thing I wanted to really go over is our framework for looking at community health, because that's the part that mostly is going to touch you. Hopefully restaurants you just assume are safe, and we'll do that in the background. You assume your doctor is not a criminal, and we'll do that in the background. But this part that we are actually actively engaging with you in is really about health and lifestyle, and assessing where people need support in terms of being able to be healthy, looking at the data, looking at what people's behavior is. So our focus is for the most part on chronic disease, because that is what really affects the wide scope of people. It is not always on, it is not always a medical issue, even though it sounds like it for many people. Hypertension is enormously impacted by mental health. It is enormously impactful on your mental health. The same can be said for diabetes. It is a two-way communication between your brain and the rest of your body. They are quite related. People who have heart problems or other issues are going to have effects from that. You can have depression or other symptoms purely from the heart problem itself and not having good circulation. You can have diabetes that impacts people's mental health, causes agitation or confusion or other things. The helplessness that most people feel, at least in the beginning of those diseases, and the amount of stress it takes to manage them all the time, and can also be a source of mental stress that causes eventual mental health issues for people. So having a lot of these really ongoing illnesses that tend to be worsening over time can be a real stress for people, and mental health is something that they need to really look after. Mental health issues also lead to physical health issues. So people who are depressed or anxious, we all know that we eat our feelings. We also drink our feelings and do other things with our feelings. So there are many, many high-risk behaviors that humans do to handle stress. Most of them are not particularly good for you. And so we look to how do we get people to understand that? How do we make sure there are other opportunities that people have the ability to exercise, which is a much better way to deal with depression than eating, much more effective, but it's not always possible for everybody, or it's not something that they know enough about to find the kind of thing they're willing to do. So all of those are ways in which your mind and body communicate. I'm going to actually not tell you about every program at DC Health. I'm going to manage to not do that and get to a little bit quicker questions, but I do want to be sure that we're talking about the ways in which you can interact with a department. If you have a number of certain illnesses, you may hear from us. Some of them are the things that you know about, like STDs. The others are if you have cancer and you are somebody who could be part of our breast and cervical cancer program, which is meant to support women in that, to certainly increase screening in women who otherwise wouldn't be able to afford it, to provide this kind of enrichment services around that help people get through that very, very hard period of dealing with their cancer initially. We have programs around exercise and mental health that you can get into. We have school-based programming around youth and risk behaviors and risk and youth health in general. So there are ways in which you will contact the department. Almost always it's through a contractor. So we use community level groups who have good connections and can recruit and speak to the community members in their particular group to deliver those services. So it does not get labeled as DC Health or being funded by the district. It is, but it is funded through a community group that you may be encountering in some other way. I am going to stop there or I lose you and ask if there are any questions about either how MindBody works for you or about how our services might be helpful to you. I'm very comfortable with silence, so I can wait you out. Go ahead.
Services through those community groups, if they maybe have a population of people impacted in their workforce that are district employees, right? Are there ways you partner with businesses or other government agencies to access your resources?
So we, for the most part, partner with individuals in most of those. They tend to be not facility based, except for our healthcare facilities. But that does not mean that they couldn't do that. So the groups that do feeding or do healthy food can certainly be contacted. It wouldn't probably be supported by the district. It wouldn't be under our auspices, but they are community groups that are available to you. And I would talk to them about whether or not that's something they can do. They are certainly funded in many ways to provide that to the community. Most employer-based education and services come through two directions, either EAP, which is the mental health part of that employee service program, or through the insurance providers that the employees are using. Most of the MCOs or various physician or other groups do have services like that. As the contractor for that employer, they can make those group services. There's some office that does the community relations or does employer relations, and that's who I would go to say, this is what we need. I'm not sure here what human resources has available, because that is another third place that for most businesses is the holder of that kind of information and helps arrange that for clients. I know they do screening because we've hosted and helped with some of those screenings, doing blood pressures or other things to help employees at least know what they should be worried about and where they should go. I'm not sure about other services that are less directly medical than that. We'd have to look into it.
I could speak on it. I'm Megan,
good.
Chief Wellness Officer with DCHR, and
There you go.
those are the exact two routes that we have. So we have the EAP ANOVA contract that's available for all employees, and then the 4 health insurance companies each have behavioral health and mental health services. So you can contact me after, but yeah, there are resources as a front line.
Do they do like general wellness services like
Yes.
nutrition or exercise?
We do. I'm gonna talk a little bit about that.
Yeah.
Perfect.
Yes.
Great.
Okay, I will go ahead. Good afternoon, everyone. And I really want to take this opportunity to thank Councilmember Bond for really holding this important conversation about mental health. Mental health has been stigmatized, as you know, within our community, and we have to really break out of the stigma and take mental health out of the shadows. I am particularly glad to be here with Dr. Bennett to talk about the connection between primary health and mental health and the necessity really to integrate both to achieve the best outcomes for ourselves as well as our residents. I think most of you are aware of the fact that the Department of Behavioral Health is the single state authority responsible for developing the system of care for behavioral health. mental health is health. Studies show that people with serious mental illness die 25 years earlier than the general population due to untreated physical illness, which includes hypertension, diabetes, and heart disease. The poor mental health is a risk factor for all of the chronic conditions that Dr. Bennett just talked about. And conversely, people with chronic physical health conditions are at risk for developing poor mental health. So it is an interactive process. So we really have to focus on whole body health. Whole person health is really our goal. More health related, moreover, some of the health related social needs impact both the chronic physical conditions as well as mental health. I cannot say enough how important it is that there is a positive connection between mind, body, and spirit. That's very important. I really want to share that it's really important to talk about how the Department of Behavioral Health supports district residents to live healthier lives regardless of their zip code. That's an important factor. Maintaining good mental health is essential to daily living. How we make decisions, how we operate psychologically, emotionally, and socially, among others. Under Mayor Bowser's leadership, the Department of Behavioral Health develops and manages the publicly funded behavioral health system to provide high quality, integrated, and culturally appropriate services designed really to support the well-being of all of our residents. Mental wellness is not simply the absence of mental illness. Rather, it is a continuum that includes factors like resilience, self-esteem, and the ability to manage emotions effectively. Mental wellness, similarly to physical wellness, is influenced by a combination of factors that interact with each other, including our biological state, our psychological state, environmental and social factors. However, it is critical for all of us to mind our mental health, not just for those we serve, but for ourselves. And so here's what you can do. I want to share the 4 M's of mental health with you. 1, movement, exercise, take care of your physical health. 2, mastery, do something that you do well, something that brings you joy. 3, meaningful engagement, stay connected, talk to others about what you are feeling. This connection can really lead to a decline in your mental wellness. And mindfulness, deep breathing, listening to music, meditation, and engaging in relaxing activities helps to reduce stress. As you see, and you're seeing a lot now in the media, the whole notion of mindfulness and deep breathing and relaxation is really coming to the fore as a tool for helping us to address our mental health. I am sure that most of you are aware that we have a robust mental health service delivery system that provided support to 45,500 residents with mental health and substance use disorders in the last fiscal year through 76 community-based providers that are certified by the Department of Behavioral Health to provide the full range of services, prevention, intervention, treatment, and recovery services. Our providers are located all across the district in every ward and allow residents to choose the one that best fits their needs. Our services are easily accessible through our 24/7 access helpline, which is 1-887-WE-HELP. A resident can walk into our adult urgent care clinic located at 35 K Street Northeast, or our youth urgent care clinic, which is located at 821 Howard Road, and be seen in the same day. Here, the goal is increasing access and making it easy to get the services and support you need. A resident can also contact one of our behavioral health providers directly and just walk into their building and get the services and supports they need. If you want a list of the agencies that are part of our network, you can get it from going to our website at dbh.gov. DBH is the call center for 988 calls, which is our national suicide and crisis line. Anyone can talk with a trained crisis counselor at any time of the day or night. But you don't have to be in crisis to call for help. You may need help with problem solving or need someone to listen to you because you're experiencing stress. You can also call for help if you're concerned about a family member, a friend, or a neighbor. And we've heard from a lot of you in terms of constituents that you have thought were in need of services and supports. Through your constituent services, you may have contacted our community response team, which conducts on-the-spot evaluations of individuals who appear to be in crisis at home or in the community, and they connect them to emergency treatment if needed. You may have also been in contact with CHAMPS, which is a specialized mobile crisis service for children and youth, or with our school-based crisis teams. DBH has strengthened its crisis services by adding staff to our community response team and the crisis call center to build our capacity to support the district's initiatives to divert certain mental health related calls to 911 instead of having an immediate law enforcement response. The CRT members also serve as members of a newly launched co-response team, which is staffed by a CRT clinician and an NPD officer. And they respond together, particularly when there's an issue of safety involved. I would like to share some good news, and that is that DC has one of the lowest suicide rates in the country, but one of the highest rates of suicide ideation and attempts among young people. Our school-based mental health clinicians promote suicide prevention. Recognizing the signs of suicidal behavior can be crucial in providing support and can prevent a suicide from occurring. Some of the warning signs are as follows. You hear somebody talking and they're expressing a desire to die or to kill themselves. Increases in substance use, engaging in risky or reckless behavior, or really talking specifically about the plan that they have made to kill themselves. These are significant warning signs that need to be acted on. If you or someone you know are having thoughts of suicide, call 988 and talk to a crisis counselor. However, if you feel that there's imminent danger for the person or for yourself, call 911 because that requires an emergency response. However, most 988 calls are resolved in the moment. A live counselor is on the phone, and the counselor will generally be able to de-escalate the situation, and if not, our CRT or community response team is dispatched. If the caller is in imminent danger and there's a safety concern, law enforcement is called. If you happen to be speaking with someone or you see someone who you think is suicidal, don't say, hey, get over it, or dismiss the person's feelings. Listen, show respect and empathy. Let the person know that help is always available and that they are not alone. Our district residents have access to a wide array of mental health services. As Dr. Bennett said, we have one of the highest insured populations in the country, with 45% of the population having coverage through our federal Medicaid program or DC Alliance. Benefits for the uninsured are also provided through DBH for our local dollar allocation. And 55% of residents are covered with private or employer insurance. Our federal and district law requires that insurance plans offer the same services for behavioral health needs that it offers for primary or physical health care. Historically, these diseases were stigmatized and treated as less than important than physical health needs. Insurance companies are required to provide clear information to policyholders about their mental health and substance use disorder benefits, including coverage limits, copays, out-of-pocket costs. All of those things are important. This helps policymakers and policyholders understand their rights and how to access the care they need. If all fails and you have questions, the DBH Ombudsman is there to educate residents about parity and parity issues. The Department of Insurance Security and Banking is responsible for ensuring parity compliance and will investigate any complaint. No one should go without the services and supports they need to address their mental health. The Department of Human Resources, as you said earlier, manages a robust wellness program for district government employees. The district leave policy supports and protects employees who use services that are available to them. We have probably the most comprehensive policy for employees that I have seen as I've worked in various agencies, mental health days, leave days, and so forth. Mental wellness is essential in the workplace. Employees who are mentally well are more likely to be engaged, productive, and better equipped to serve the needs of our community. Mayor Bowser, with the support of council, has invested in building a strong public health system to address behavioral health and related social determinants of health, such as housing and supported employment. Mayor Bowser's proposed FY25 budget for DBH includes $29 million to fund supported housing and matching funds to support the delivery of Medicaid billable services, both of which are crucial to recovery. I want to end by once again saying it is critical to mind your mental health and know what services are available. Share that information with your constituents, your neighbors, and your families. Remember, we are only a click away or a phone call away, so please access those services. I want to really thank you for the opportunity to talk about how DBH works to promote prevention, treatment, and recovery for behavioral health disorders. I've spent my life working to support people with behavioral health disorders. And I am really heartened by the public's interest in understanding the mental illness and substance use disorders, and that they are diseases, not a personal failure or a source of shame and embarrassment. Conversations like this one are extremely important to encourage people to seek the help they need. And I want to share with you, just like there is physical health first aid, there is also mental health first aid. Mental health first aid really gives you the tools that you need to address mental health issues that you may encounter within your work. This was developed by the National Council. These sessions are available for groups. And if there is interest, then we certainly are willing to facilitate that process. So thank you, and I will welcome any questions that you have. Yes, ma'am.
So we have through your agency, I know you mentioned the hotline, something specifically targeted for seniors throughout the city that may experience some type of mental distress as a result of possibly isolation or different mitigating factors.
I'm so glad you asked that. Through our Access Helpline, we actually do have a warm line function. And what we find is that there are individuals who are very lonely and feel really distressed because of it, and it does impact their mental wellness. And so they call in on a routine basis, and they have an opportunity to talk to mental health professionals around what's going on. And we find that some of them are scheduled. They call like every so often, and they're on a schedule, and somebody can talk to them. So we have that, and we are actually planning to not only expand that, but also one of the things that we are working towards is a text and chat line. Because what we're finding, particularly with young people, they don't necessarily want to talk to you. They wanna, because they're a part of this generation that uses their cell phones and they text everything. And so we hope that that will be coming online soon. This is the Mental Health America curriculum. This is the Mental Health First Aid, I'm sorry, curriculum. Huh? What? Yes.
So are there staff people at DBH who can facilitate the mental health first aid?
Do what?
Or do you have staff people available to facilitate the mental health?
Sure.
First aid? Okay.
To organize, of
Yeah.
course, because there is the National Council for Behavioral Health.
Okay.
They are the providers and the trainers, and so yes, we can organize that on behalf.
So who would be the best person to reach out to?
You can call me directly.
Okay.
And we can get that, or you can call Malcolm
Okay, thanks.
directly to get that organized.
Thank you.
Okay, I think we're gonna.
We have a cabinet meeting this afternoon at the same time, so we are going to leave it to you, gentlemen.
Dr. Gifford.
Okay, give us just a moment.
Sorry, we had to leave.
Okay, great.
You're going first, right?
I think me. I think he asked. You want me to go? Yeah. So he wants to.
Would you mind moving to the side?
Sure. Yes. Yeah, because mine are done. Based on content. Okay, excellent. Yeah.
Get here. Right. On. Almost.
Great. Thank you. So first, thank you very much, Councilmember Bonds and the staff for having me. It's a real pleasure to be a part of this very important event. So I will be talking to you a little bit about stress, anxiety, and depression, and talking a little bit about the importance of assessment, which is sort of going to be part of the sort of take-home message that I would like to leave you all with in our brief time together. So first, turning the slides, should I do any? Oh, I'll just let you know.
Yeah.
Okay, sure. Next slide, please. So when we hear about these things, stress, anxiety, depression, I think very understandably, they have very negative connotations. So I think these are just things you don't want. These are just things which are problematic, which is of course in part true. But what I like to remind everyone of is the stress, anxiety, and depression. These are all actually aspects of personality traits that have evolved through time to in part help individuals get through difficult matters. So they're also very functional and they're also very adaptive from an evolutionary standpoint. So for example, have you ever heard of the lazy, easygoing caveman who just slept through the day and didn't care about anything? You haven't. Next slide, please. Because those folks didn't make it. In order to survive, that these kinds of fundamental aspects of anxiety that help folks be hypervigilant, to be aware of their surroundings, to be a little bit cautious, are very, very adaptive and very necessary. So that's an important point when we kind of discuss some of these things. Next slide, please. There's a curve that we psychologists and a lot of folks in the life sciences love called the Yerkes-Dodson curve. And this has been used to explain a lot of things in the sciences, but it's really helpful to talk about some of these aspects of stress and anxiety. So the idea here is simply that when you start out with a task that you want to do, or you're taking an exam, you have a little bit of anxiety at the beginning, and that anxiety is helpful and adaptive. It helps you focus and increases your performance. And there's that sort of top of the graph optimal level of anxiety, right? Where you just have the right amount, that you're just focusing, you're getting the task done, you're able to be successful. But then if you have more anxiety or more stress above that, that's when you get into problem area. That's when the anxiety is keeping you from achieving your goals. That's when your efficiency really goes down the curve. So it's really helpful to look at that in issues of anxiety, but also with stress as well. Next slide, please. So we kind of see the same thing with this idea of stress and burnout. When you're working and you have a little bit of stress, maybe when you're trying to complete a task can be helpful, it's helping you get things done. But then if the stress keeps coming, you have trouble focusing, and then you eventually get into that area that we call burnout, where you're just not able to focus at all, when everything just seems impossible to achieve. And the key is really for each individual person to identify where that top of the chart is for you, right? Where are you just having the right amount of anxiety and stress, just actually adaptive, helping you, getting your goals done, and not going over into that area where it's really inhibiting the performance of those goals. Next slide, please. So in clinical psychology, we talk a lot about these terms, significant impairment in occupational functioning or in relationships. And that's one of the key criteria that we look at to see if the amount of stress, anxiety, or depression someone is having is really causing them to have a clinical disorder. So is the anxiety causing you to not achieve your goals? Is it keeping you from going to work? Is it keeping you from going to class? That's when we get into sort of this territory of disorders, as opposed to just functional anxiety and functional stress. The other component, client distress, that may seem a pretty obvious one. Obviously, if somebody's feeling a lot of anxiety, a lot of stress, they're going to be distressed. But that can also get quite tricky. And maybe you all know folks like this that work really hard, and to everyone around them, they seem like they're really overstressed and they just have too much anxiety and they're going through burnout. But if you ask the individual, they might say, no, actually, I'm doing great. This is how I operate. And they're not really aware of sort of the world collapsing around them. So that's where we get into quite tricky territory, where the importance of social networks, therapy, intervention really come into play to help individuals kind of realize that, no, this is actually not helping you achieve your goals. You're kind of over that Yerkes Dodson curve. Nerdy psychologists, we check in on each other and we kind of say, where are we on the Yerkes Dodson curve? Are you doing well? Are you doing bad? So it's kind of a nerdy little lingo that we have between each other. Next slide, please. So I'll talk a little bit about some of the underlying biological pinnings of anxiety. Of course, we can't get into the plethora of research available here, but I'll just share with you some sort of fundamental things that we know. In terms of anxiety, it's often related to this neurotransmitter called GABA. And GABA is an inhibitory neurotransmitter. So basically, this is the neurotransmitter which calms things down in the nervous system. So the idea is that when someone starts to get anxious, the anxiety goes up, your cortisol levels go up, your adrenaline goes up. And then at some point, GABA will kick in and keep you from going too far, from having a panic attack, kind of staying at that normal level. But for folks with anxiety disorders, the idea is that as this cortisol level increases, as the anxiety increases, GABA doesn't kick in when it should. There's not enough GABA response, and they just keep going, possibly having a panic attack, possibly having a breakdown, possibly experiencing anxiety disorders. And that's why a lot of anti-anxiety medications focus on GABA as one of the primary components. Next slide, please. So let's talk a little bit about major depression. Here are some of the key clinical identifiers of depression. So according to the manual that we all use for diagnosis, you have to be depressed for 2 weeks at a minimum. This also comes with some cognitive symptoms. So very famously for anxiety and depression, folks that have these disorders, they have sort of an unrealistic view of the world. So for example, they may have something really good happen to them, but all they're going to see is the really negative things. The example I like to give is if somebody with a very severe anxiety disorder wins the lottery, for example, you might think that's great, fantastic. But in their mind, they might think, oh, what about all the taxes they have to pay on that ticket? What about all the negative things? So they constantly reinforce this worldview that just makes their depression and anxiety realistic to them. And they sort of have blinders on to sort of some of the realistic components. Disturbed physical functioning. So folks might have poor hygiene. They might sleep too much, sleep too little. And then there's this classic symptom called anhedonia, which translates literally into lack of pleasure. So if I'm trying to diagnose someone very quickly with possibly a depressive disorder, one key question I might ask is there anything that you used to enjoy that you don't enjoy anymore? So somebody might say, I loved going out with my friends, but now I just don't enjoy it anymore. I love going to the movies, but now I'm just emotionally numb to it. I don't care. And that's one of the key criteria of major depression, this lack of ability to enjoy things that you used to enjoy at some point in your life. Next slide, please. So depression comes in a lot of flavors. There are a lot of variations. There is sort of a more genetically based depression where, for example, somebody might have things might be going great for them. And all of a sudden they wake up and they're depressed and they really don't know why. That can and does happen, but that's more rare. If you ask most therapists about their common clients that are coming in for depressive episodes, most typically it's someone that things were going okay, but then they had a major stressful life event happen, something unexpected. Someone died, a major job loss, a divorce, and they just find themselves unable to cope and kind of spiral down into depressive episodes. And that's where we get some really interesting discussions about when do you actually call that coping mechanism a depressive episode? Is it just normative dealing with stress and anxiety based on something bad that happened? And when does it cross that threshold into now it's major depression, now it's anxiety? That's not an easy question to answer, and that's one that psychologists in the profession are always continuously grappling with and kind of changing that benchmark. The reciprocal G environment is really this idea of reinforcing that depressed or anxious worldview. So if someone is very anxious and they think of themselves as never possibly amounting to anything, they might not seek out that job, which is going to help their careers, or that relationship, which is going to improve their life. They might just think, no, this is the best I can do. I'm not going to try to get anything anymore. So in a sense, they're reinforcing that worldview of being anxious and depressed and just confirming it for themselves. So it becomes a sort of vicious cycle that constantly keeps turning. Next slide, please. So I was just talking a little bit about also communication, and I'm a big fan, if you haven't noticed, of alliteration. So if I was to kind of boil down key components of communication, good communication between family members or couples that minimize aspects of depression and anxiety symptoms, it really comes down to veracity and validation. So veracity in this case means just really being truthful. So when somebody's really having a bad day or somebody's really frustrated, to be able to tell their family members or their partners what's really going on, not try to sugarcoat it or gloss it over, but be very direct and very honest. On the other side of that, there's validation. So the family member or the partner has to validate and say, no, be very understanding, understand where that person's coming from, and then deal with it accurately. When I've done couples therapy, it almost always comes down to these two aspects. One partner often isn't honest about what they're feeling, and the other partner isn't validating some of those emotions when they are honest. And communication between those two factors in that dynamic is probably one of the most important things we've worked on. Next slide, please. So I'll talk a little bit about treatment. This is, of course, you could do many hours on the controversies involved in treatment and medication. So this is a big question. Does medication work? Does therapy work? There's no question that medication has been life-changing and has really saved people's lives and has been sort of this massive revolution in the field of mental health treatment. However, I would suggest that a lot of the issues that we're now facing with misdiagnosis, over-medication, inaccurate medications come down to this problem of assessment. And really an improper understanding made perhaps of when medication should be used and when the proper diagnoses should match up with medication. Next two bullet points. Thank you very much. So most of the common antidepressants that are on the market belong to this family of SSRIs. Examples are Prozac and Lexapro. Again, this was a major revolution in our field and it's helped countless individuals. But at the same time, you may be surprised to learn that the typical provider of antidepressant medication isn't a psychologist or even a psychiatrist. It's a general practitioner. So someone you might go to, for example, if you have a migraine. This individual might not have any training in psychology at all. They may never have taken a psychology class, yet they are the folks that are prescribing the most of these psychiatric medications. So when we get to these questions of inaccurate diagnosis or overprescriptions or things that really don't alleviate the problem, but sometimes make it worse, that in part, I believe, is some of the things that we're grappling with. One type of therapy that I really want to throw out there, and I think this is therapy is pretty mainstream, so probably a lot of you have heard of it, is cognitive behavioral therapy. There's many therapies available to individuals, many types of therapeutic orientations. But if we're talking about anxiety, depression, I would suggest that cognitive behavioral therapy is definitely one of the most scientifically, empirically validated therapies. And I'll talk really briefly about how it works. It's a very simple and easy to grasp model. Next slide, please. So the idea here is, just as I was mentioning before, folks that have anxiety and depression, they tend to have irrational thoughts, unrealistic perceptions about themselves and the world. And if you look into the research literature on depression and anxiety, you see many examples of this. Next slide. Here are just some common sort of thoughts or anxiety-producing thoughts that folks have. I'll never be happy. Nobody was ever good enough for me. Imagine people that just constantly live in that worldview and never thought of an alternative. So what cognitive behavioral therapy does is it targets those thoughts. It teaches individuals to identify them when they have them, and then replace them with rational, adaptive thoughts that are more connected to reality. And pretty much empirically, cognitive behavioral therapy for depression and anxiety really is the treatment of choice because we see so much of these irrational thoughts underpin a lot of anxiety and depressive symptoms. And the other great thing about cognitive behavioral therapy is it's very amenable with all sorts of other therapies that are very common today. Dr. Bazran mentioned some of them: exercise, meditation, mindfulness, EMDR, acceptance commitment therapy. These are all therapies that can be used in addition to classic CBT approaches, which this combination really help with these depressive anxiety symptoms. Next slide, please. So I'm going to leave you with a couple of thoughts and tie it back to this idea of assessment. You can just kind of put all the bullet points down. That'd be easier. One more time. Right. So imagine if you're going to a doctor and you're concerned about having high cholesterol, and the doctor gives you a cholesterol test. You assume that that test they're giving is an accurate measure of your cholesterol. Have this assumption. And most of the time, that's probably pretty true. Unfortunately, that's not the case in our clinical professions. That you might go to a general practitioner or a psychiatrist or another mental health provider, the assumption that they're going to accurately diagnose you with depression or anxiety or PTSD. But unfortunately, that's not necessarily the case. The measures they're using are necessarily the most scientific. The whole way that we approach diagnosis, I think, is very, very problematic, which leads to a lot of problems, misdiagnosing individuals, and then coming up with treatment plans and medications which are inappropriate for those folks, which make the problems worse. So I know this is a government crowd and folks are very interested in policy. So I want to leave you with some thoughts on possible avenues for future policy. But this may be something to explore. How can we revise our mental health diagnostic system to serve our constituents better, to make diagnosis more accurate, to make sure that folks are getting the treatment that they actually need the most, as opposed to an inaccurate diagnosis or medications which don't really line up with what folks really need. So that's really the little bit I want to leave you with, sort of as a final thought. Thank you very much for your time, and of course, very happy to take any questions or comments. Yes, Becca, please. Yeah, great question. So yeah, personality disorders are a component of the diagnostic sort of ability that we have. So we have mood disorders, there are different categories of disorders, and one of those categories of disorders are personality disorders, which come with their own unique criteria and are famously distinct because there is no medication that has ever been shown to work on personality disorders. So when folks get together to kind of revise diagnostic criteria and think about how to change personality disorders, that's always an extra challenge because they're very difficult disorders to treat therapeutically and virtually impossible to effectively medicate for the personality disorder itself. Yes.
You hit on something because frequently I hear from individuals, let's say in this building, and that they believe a coworker has a personality disorder. So help us, please. Figure out what can we do? How should we behave when we, it may or may not be true, obviously, but because we work in close proximity to each other, it's pretty easy to say, oh, she's acting up today. Oh, watch him or what have you.
Yeah, it's a great question. I really appreciate it. So this actually gets back to a really important point about the distinction between sort of more normative behaviors and clinical concerns. So there are a lot of folks that have personality quirks and eccentric personalities. That by itself wouldn't classify as a clinical disorder. Probably most of the population would have something. But to me, personality disorder, it has to be really ingrained in your personality and something that's consistent across situations and individuals. So for example, if somebody is very impulsive, it wouldn't be just with one other person or in one scenario, it's across all the different scenarios of their life. And that's one of the kind of fundamental distinctions between sort of a personality quirk or just a little bit of eccentric personality. And then also that distress component. Are they really symptomatic to the point where they're interfering with their goals in their profession or really destroying their relationships. And if that's apparent to folks from the outside. Because the interesting thing about personality disorders, as you kind of alluded to, often folks that might have them, they don't think that there's anything wrong with them. Think about narcissism, for example. Never in the history of mental health treatment has there ever been a situation where somebody's gone to a psychologist's office and said, "Doctor, I have narcissistic personality disorder, please help me." Because by definition, they don't think anything is wrong with them. That in part what makes them so difficult to work with or to live with. So I hope that gets at the very excellent question. Yes.
So how do we handle that?
Join the club. Yes, to date, there's only one personality disorder that I'm aware of that has a scientifically supported treatment, and that's something called borderline personality disorder. The treatment for that is dialectical behavioral therapy. But outside of that, there's a whole bunch of personality disorders like narcissism, histrionic disorder, many that really have no treatment. And for therapists, that's an issue too, because if we get one of these folks in a therapy session, maybe because it's court mandated or a relationship ultimatum, it's really tough for us. We really have very little to work with because nothing can really ultimately help some of these symptoms because they're tied to someone's personality.
So do you have advice for us in the marketplace? What can we do? Because we want to get the work done.
Yes.
We have goals and somehow, let's say, there are personalities that seem not goal oriented. That hold you back or keep the product from being realized. So how do we deal in these situations where we've got maybe many different personalities?
Sure. Well, I would kind of go back to my earlier thoughts on assessment. So assessing folks for what they come in with, or even before they start working, to see where their strengths lie, where their personality fluctuations may be, and thinking about the ideal setting. Maybe somebody isn't great in a team. Some folks with personality disorders, one of the criteria is they're not going to be great to work with. Think about working with someone who has narcissistic personality disorder. That's going to be very tough. So if you know that coming in, then you might say, okay, well, maybe this is going to be better suited for a job where they're not working in it, or you can kind of delegate from that. That's really the best you can do because you can't really treat them, and confronting them usually isn't going to be very effective either. Yes.
So our human resources department to assess all of us to determine who we are, where we seem to be.
Well, I would advise that just for anyone individually to kind of know about themselves, that then you can kind of know your own strengths and also guide your own sort of decisions. I don't know if I endorse that necessarily as sort of a blanket policy, but I think it's definitely something to consider. And to your point, there are really good assessments that I could maybe suggest that I think accurately capture some of these things, and not so great ones. I'll give you a quick example. A lot of folks have heard about the Myers-Briggs test. This is a very popular test. Is actually a very bad test, despite its popularity and despite how commonly it's used. If you look at the sort of science behind it, it leaves a lot to be desired. But folks are making really serious decisions sometimes from that test. So that's where we can see a lot of policy improvement simply on that level.
So what is a good?
Oh, please, let me hand over to my esteemed colleague.
This is you're gonna be really tough. We're gonna break bread. I'm a behavioral neuroscientist. I'm also a clinical psychologist. Your question really begs the issue that a lot of people have to navigate when they work in an environment with a lot of people with proactive personality. I would suggest.
And you are?
My name is Dr. Well, I'm Niana Rossianis. People think will come up.
All right, okay.
My students taught me Coco and Tony, which simply means teaching. But to respond to your question, which is a question that does not impact you all in government, but it's throughout everywhere in academia, everywhere you go, you find people that are on the spectrum that present different features of personality disorders, but we can't diagnose them because of their position. So I would suggest in that situation that you all visit HR and suggest to HR that you invite someone like Dr. Ufik or myself, and we're in DC, so we're always pro bono, to come in and do a training on the different nuances of people's temperament and how it may undermine the work environment. That way, no one will be singled out. someone will come in to do a panoramic picture of these types of things so that you will know you will not be singled out. Because when you have supervisors or administrators that are presenting the spectrum of this gamut of personality disorders, they can be narcissistic, they can be paranoid, they can be incredibly intrusive, they can be any number of things. So in order to avoid putting someone beneath the spotlight, it's always a good idea to bring in some professionals to come in and globally address those issues. And then people can chime in and say, we need more training like this. And believe it or not, people that have personality, particularly narcissism, they will overtly engage in whoever comes in because they oftentimes want the attention. And a lot of times they know they're narcissistic. You follow me? But they just don't give a flank about being narcissistic. And they're also in a position of power. So in order to minimize the individuals that made the observations to being put on the spot, you bring in professionals to sort of like highlight the panoramic view of these types of things. And trust me, it will percolate. It will come to the surface who presents those types of things.
Let's have one quick amendment to that. I'm not so sure about the pro bono aspect. Sure. For so for a personality disorder called borderline personality disorder, which is marked by impulsivity and sort of a roller coaster of emotions, we have something called dialectical behavioral therapy, which has been shown to work really well for those folks. But outside of that, and feel free to add in if you have thoughts, I'm not aware of any empirically supported treatment for personality disorders. So if you're in a situation where you're with somebody who might have that, or you have those concerns, best to get sort of professional consultation for how best to navigate it. It's going to be very individual depending on type of disorder and things like that. But unfortunately, as much as we wish they were, there are really no good empirically supported treatments for most of these. If you think about it, it kind of makes sense why it's so challenging, because it's really your personality. It's inherent, it's who you are. If you've ever tried to be in a relationship where you said, I like this person, but there are certain things about them I'm going to work to change. Think about how that worked out. I'm just going to predict probably didn't work out great for this very reason, because it's inherent personality traits, which are very difficult to change. Oh, great question. So that's really the threshold between something that's impairing or causing the person distress versus sort of personality traits, which might be habits, which don't really cause sort of consistent impairment across situations. And that's really that threshold which you're looking at from a clinical standpoint. That's cool. All right, thank you. All right, I'll hand it off to my colleague.
I'll get yours on just a second.
Okay, my PowerPoint's going to plug in momentarily. First of all, I'm absolutely honored to be here. I'm sure she's going to pull it up in a couple of moments. And I'm a behavioral neuroscientist. I have a master's degree in clinical psychology. I used to be the chief psychologist of the National Children's Center. The reason why I'm sharing this with you, so you have some general perspective about who's sharing information with you, what my background is. And interestingly enough, a number of things that come out of Dr. Youth share with you will overlap what I'm going to share with you. We can skip that little thing about yours truly and just jump right into the name of the presentation. I think she just had it on the screen. It went away. So you're finding it? It has now at the end of it. Given while she's pulling that up, my presentation, the title is Redefining Wellness, Brain and Mental Health in Urban Environments. And hopefully that slide will pop up momentarily. That's the slide, okay? So again, I'm a behavioral neuroscientist by training. I'm an associate professor at the University of Columbia. And I was once the chief psychologist at the National Children's Center. The reason why I'm sharing that with you so you can have perspective. If you look at that diagram, you're going to see references to talk about the general socioeconomic, cultural, and environmental conditions, the community, the individual, and how this constellation impacts the family. Go to the next slide, please. And I'll just lean back and give you a little wave, all right? You see, mental wellness matters. I see people all the time, but they don't understand that physical health is tied to mental health. And mental health is intimately woven to physical health. Because oftentimes people will have physical quirks and things about them that they aren't going to tell you about. And they will manifest themselves psychologically. Like you may find people in this country that are obsessed with being thin, obsessed with cosmetics, obsessed with their phenotypic presentation. And a lot of that has to do with the misogyny and how we generate policies in a society to deal with so-called skinny people, plump people, medium-sized people, muscular people, facial features, hair, skin color, and the whole 9 yards. So you have to be mindful that your wellness is going to impact your collective physical health. We can skip the next slide, go to the one behind it. Go to the next. You see that? I want you guys to browse that just briefly. And as you're browsing that, I want you to be mindful of a number of titles beneath each little profile of the face, and you will see, for example, like sleep disorder, it's going to stand out completely on its own as being something unique that may not have any particular type of causal agent, because there could be a variety of things that could be endogenous. As my colleague mentioned to you about GABA, gamma-aminobutyric acid, which is going to calm you down and allow you to go into chill mode. But there is another compound that could dance around that he alluded to called cortisol. Now, I just wanted you to browse that because I'm going to take you to the next slide to share with you how these things translate into particular behaviors that we would view as a mental health problem. Next slide, please. Okay, you see that particular arrow, you see the red zone, you see the green zone, and on the far left, you see disease, and on the far right, you see optimal health. In a couple of moments, I'm going to pull up another slide to share with you how those things set you up to actually present in the spectrum of the arena of what we would call a mental disorder. As my colleague was talking to you a little while ago, your adaptive behaviors, your maladaptive behaviors. When your behaviors become so maladaptive, like people that may have personality disorders, when they become so intrusive that they screw up everybody else's workday and impact your ability to do your work, but they're in a position of power, then those people are actually presenting under the rubric of what we would recognize as a mental health condition. But because they're in a position of power, who are you as a quote unquote subordinate to diagnose them and make that observation? You could put your job in jeopardy. And there is a saying, an axiom that comes from Taoism. It's like, you don't tell people at work what you do away from work. You may think they really want to know, but they really want to know what kind of life do you have away from that work environment. And oftentimes they're just being nosy. Neither you discuss those things at work when you have issues about the dynamics of how things are done in the work environment. Because you will be the one that will be highlighted, to not necessarily be thrown under the bus, but it will be, well, just like blah, blah, blah said. And then they'll highlight you to expand on whatever that phenomena is. And so when the consequences come down the pipe, you're in no position to say that person has a mental health disorder. But when you look at the red zone maladaptive behaviors, when your behaviors constantly put you in harm's way or undermine other people or do something that takes you out of your level of functionality that's optimal, then you are presenting in the arena of maladaptive behaviors. Next slide, please. You see that little symbolism there? It's very obvious. A lot of people, they don't want you to know what's going on inside of them. We have a culture where people will say to you, and I like this one because I'm processing some information now that I will not go into the detail, but the reality is, how many of you heard people communicate to you this way? And children can see through it. Something can happen very traumatic in your life, and they'll say, oh, I'm sorry to hear that, Jeff, my condolences. That's like a generic comment. The average person knows that you're just saying it if it's not coming from a place of empathy, and particularly adolescents. If you don't come close to them and acknowledge some cultural congruence and tune in to where they're coming from, it's like, what? Seriously? For real? How are you dealing with that? You have to engage them. But our traditional intervention protocol oftentimes will make us default into what we've been trained to do. So people will have that anxiety within them and behind them, and they won't disclose it to you. Unless you have what every clinician will tell you before you do anything in diagnostic assessment is you must have rapport. They must have some degree of belief and trust in you before they disclose anything. Next slide, please. Everything that we're talking about now can be directly related to health psychology. Now, I want to highlight what you see highlighted there. You see the green, the yellow, and the red. This is the elephant in the room that people rarely choose to overtly engage. As a matter of fact, it should be in the DSM-5. They haven't put racism in the DSM-5 yet as a mental health condition, have they? Is misogyny in there? That's not in there either, okay? And we know how misogynist certain people are when they get in power, particularly obviously a male who's presented as a cisgender binary male. We know the toxic environment that people have to navigate. As a matter of fact, there's one going on at this very moment in the news out in Virginia. I think there is a Baptist church or something, and the church people have decided that they don't want any female priests preachers in that particular church. And it's going back and forth, all right? And so what happens is there is a mindset that comes from society at large that allows these things to take place, even though they may take place in areas that seem to be compartmentalized. But there has to be a larger rubric for us to continue to do those things. Next slide. You see at the corner where you see the red zone, and you see people dealing with beneficial stress. When my colleague was talking to you, he made a reference to cortisol, but he also made a reference to some of the classic anxiolytic drugs for depression and general stress, like they may be in the Xanax family. Prozac is a heavyweight one. You follow me, to actually deal with a clinical depression. But Valium and Xanax will be something that people could get in a heartbeat from their regular physician. And they may give you that Xanax to sort of like pacify or put a Band-Aid over what's really stressing you out. And when you do that over a period of time, your body will need that in order for you to regulate your own behaviors. And you will be oblivious to how critically important it is to be mindful of having certain types of foods available to you. Next slide, please. So when you look at this next slide, we can skip that one, go to the next one. This one is critically important when you talk about what's happening with our youth and adults. I'm always the one that will drop the bomb about the elephant in the room. Most people think racism is something that's polarized around these psychological and social constructs referred to as different ethnic groups assigned race. But you only have humans. You follow me? And I'm going to give you a condensed version of what a human is in a moment, because I'm going to show you a slide of what a human really is. But we get polarized into the ignorance of ethnicity and religious orientation. And what is your phenotype like? If your phenotype is a particular way, or you wear this particular type of makeup, or you wear these types of clothing, people will say your phenotype or your body type does not allow you to do that. People will also say, I love to do this when I'm on the Green Line in Washington, D.C., riding the metro occasionally with the kids, because I collect data there. And you may not know it, but oftentimes there's a term called ebonics that a lot of youngsters use in the District of Columbia. Ebonics is when they add that extra ED to a phenomenon. You know, like, I really liked you when I first saw you, okay? And then they would say, you really got some good hair. I've had kids to pull my ride off my head in the train and say, damn, why you got all that? And I call it platinum. But the point that I'm making is people will judge you based upon how you look. And if they think that you look at a particular age, like he was saying, interpersonal skills, they will approach you based upon how you present. It's no different in a therapeutic relationship. If you don't have cultural alignment, like Washington, D.C. has a lot of services available, but a lot of those services that they have available, they may not realize you cannot use that Eurocentric model to expect a teenager or some Latinos or some people from certain neighborhoods to come in and talk to you 3 times a week about what's bothering them. You may have to shoot them a text, give them a shout out, ask them what's the last thing they've done recently. But we have all these guidelines that say we must collect their data. We must assess whether or not the person is having suicidal ideations so that we can deal with all the dot the I's, cross the T's in order for our documentation to get third-party payment and also fit the nomenclature for the DSM-5. Because if you don't have the right label and the right title, and oftentimes intervention is driven by the label. Like you said, it's very difficult to treat people that have personality disorders because they cover the spectrum. And usually, like if you have a narcissistic person or a person that's obsessive compulsive, they may think very swiftly, they may have answers to a lot of things, they may explain to you why they're there, and they may tell you, that's why you're here, I need you to do that. And they will manipulate the crap out of you if you allow them, because oftentimes they are much more knowledgeable than you are. So this particular symbolism that you see with these brains, I'm going to give you some perspective about young people need for intervention and why it's so awkward. You see the red area highlighted on the brain stem, you see the blue area highlighted in the midbrain, and you see the green area highlighted in the frontal lobes and the frontal cortex. You may not realize it, but when you're younger than age 22 or younger, if you are a melanin dominant person, so-called African American, those individuals oftentimes when they see people that they think have been assigned to help them, there is a major element of, am I okay talking to you? Can I really disclose to you what's going on? Can I just tell you candidly, I don't want to talk to you. I know the court said I'm supposed to talk to you, but I don't trust you because they're worried about security. Now, when you move up to the other level of the brain where all the emotions are dancing around at, and you may not realize that that red zone also relates to emotions because it relates to safety and security. If I don't feel safe and secure, you're not going to get much from me. And if I feel like I can engage you emotionally, I may play a lot of games with you, find out whether you have buttons, find out whether why have buttons. But when you become older and you have resources in place that you need, then you can do a lot of things from your frontal lobes. Piece of information you need to know. That part of the brain that you see in green, the dark green, it doesn't even develop until you're in your late 20s, okay? And teenagers, I'm sure you've seen little kids. You ask little kids, why you do that? I don't know. And they'll do it again. And they'll say, why do you keep doing the same thing? I don't know. And then the kids will say to their parents, like, Mommy, can I have some chocolate ice cream? Well, baby, we don't have any chocolate ice cream. I want some chocolate ice cream. I'm talking about kids that are younger than 12, all right? I want some chocolate ice cream. I just told you we didn't have any. Mommy, why you lying to me? Don't talk to me like that. I ate all the chocolate ice cream. What you mean you ate it all? The ice cream where you had the chocolate, the kind of red strawberry and white, I just ate the chocolate. And the mother said that was Neapolitan. But the kid is like, no, but that part was chocolate. And that's all I ate. And see, they will think outside the box. And when they think outside the box, we will have a confrontation with them because they aren't into all that rational stuff in the frontal lobes. They just want what they want and they'll give you concrete answers. And when you ask them, did they eat all the ice cream? They will say, no, I didn't. I just ate the chocolate. And see, you're confused by that, you per se, but the parent will look at that like, why are you lying to me? That's because you don't know children and you don't understand that they do not operate out of the concrete logic that you operate out of. Now, to summarize the symbolism in these brains and how it relates to racism, the average vanilla brother, Caucasian male over the age of 35, when he sees the blue light or red lights behind him on the freeway, he doesn't go into shock mode and say, like, am I going to make it home? You follow me? Or did I have to talk when I was growing up? Or should I just kind of like try to like outrun this policeman? He's not going to do that. The kid that is younger than 22 years of age, or the person that's a so-called immigrant that's coming here, they want to fit in. You may not know it. A lot of people that come from other places in the world, they will change their name to make it more Americanized. I know Muslims, I know Asians, they will come here, the name could be Zenwan Fu, and they will say, everybody calls me Ann. And you might meet Michael, and Michael's name is actually Mahfoud, all right? But my names are not that well accepted in this country. You follow what I'm saying? So people will ascribe a number of things onto you based upon how they've been socialized, and their brain will engage automatically. Next slide. We've been setting the stage to talk to you about, go to the next one, and go to the next one, because we don't need to go into all that. Stop there. You see, come up to allostasis. Back up one. See that allostatic load? That's when the stress becomes too much for you. You don't know how to cope. Even though we've already passed Valentine's Day, there are a lot of people. You realize that a lot of men break up with people around Valentine's Day, before Valentine's, because they're worried about buying stuff. And they may come up with a reason to just kind of pull away from you. And all you just wanted was a card or an acknowledgement or maybe a little box of chocolates. But he may be tripping over the fact of like, I can't buy you a gift. You make more money than I make. And he's stressing, and he may not even see you until weeks after Valentine's Day because he went out and got a little tipsy because that was his way of coping because he couldn't handle the stress. And you see the stress overload in this vehicle here that will remind some people of the Beverly Hillbillies. I know that's dated for you people that don't know what the Beverly Hillbillies are, but it stresses you out. So let's go to the next slide because I'm going to have to take it to the brain and then we'll start condensing some things. You see this child? You see all these things going on inside of her head? You see all these different diagnostic nomenclatures that pop around inside of her head? She doesn't have a clue who she is because she's socialized to get her identity from what the media tells her. And the media will give her all these things. It's not enough people in this room to know, but I guarantee you when they had Barbie dolls, when they first hit the scene, they didn't have any brown Barbie dolls, bronze Barbie dolls. They just had a vanilla Barbie doll. And when they got chocolate Barbie dolls, the Toys R Us and the stores would sell out of them in a hurry because the kids wanted to get the dolls that remind them of who they are, and that's what their parents wanted to have. Now, how does all this relate to mental health? Go down to my next slide. Next slide. Next slide. Next slide, because obviously I have a lot of stuff. Go to the next slide. And we can deal with that one for a moment. You see that stress load, long-term stress? These are the things that are going to make you present mental health problems. The average person is going to tell you that they have irritable bowel syndrome. You've seen all the commercials on television, people are happy as I don't know what, right? You have the Anderson Nations call, they play nice music, you're jumping around. I've seen the Vanilla sister, she's dancing around, well, she's actually Latino, Chicano sister, she's dancing around. I have diabetes and I'm taking my medication, and then you hear about all of the side effects, right? And then the music gets really, really nice again. You know, dancing around again, the colors change to make you buy it, right? Shortly thereafter, commercial will come on with dogs or pets. And then you will see people putting people out for their pet because they're selling you the dog food, right? So you're dealing with this emotional roller coaster of trying to process all these things. And while you're trying to process all these things, you are losing your sense of identity. You don't know what you need to do. That's where the neuroscience comes in at. We program you and you don't even know you've been programmed. And if you're a young person, you're not able to figure that all out. And young men and young girls, guess what they do when they oftentimes get depressed? They become argumentative, they become confrontational, and they oftentimes engage in unprotected sex because they're looking for some pleasure. They're looking for some escapes from those things that stress them out. Now we're going to go to the slide that highlights some things for the brain. Go down, leave it there, all right? That particular slide, because I want you to know how toxic stress in childhood alters the brain. You see that thing look like a larger map where you see normal, and then you see toxic stress. Your brain development diminishes dramatically the more stress you are. I bet you there isn't anyone in here that could drink 2 Coca-Colas, 16 ounces, just back to back, just straight down drinking them without feeling that little burn in the throat or on the tongue, all right? Now, I'm not saying you can't do it, but you're going to feel that burn because of the phosphoric acid. Now, cortisol does a similar thing while kids are developing their brain. And so when you get that stress over and over again, you're basically diminishing your brain cells' ability to develop and thrive. And over a period of time, you become reactive. Add the sugar with the phosphoric acid in the Coca-Cola or the pops, then add the extra stimuli, the caffeine in the monster drinks, and you are giving your children brain damage. But they don't know they're getting brain damage because they may decide they want to eat some potato chips or whatever to kind of like put a little salt in their bodies so that they can just have something to buffer it. And now they're setting themselves up. Go down to the next slide. This epigenetics, next slide. That's a summary of epigenetics. I'm going to share with you how this works. I know a lot of people, they said it's regular. Hey, what is it? You think it's genetic? Do you think it's the environment? We finally come up with a word to let you know it's both, all right? It's how the environment impacts your gene's ability to express. So go to the next slide. You have 3 brains. We finally begun to tell people that a lot of the behaviors that you see in kids that are on the spectrum is something called the human biome. Whatever is happening in your gut can throw off what's going on inside of your head. You see what they say, body serotonin involved in mood and management is produced in the gut? 90%. Serotonin is always tied to your mood, your temperament, all right? And as you see heart and you see brain, there is a relationship between your gut and your heart and your brain. I know you all know, like I made a comment about rapport. We wonder why a lot of these kids that we have in therapy, they have something called community-based intervention in the District of Columbia for a lot of these youngsters that are jacking your cars, going off on people, not being involved with therapy, not following through what the court mandates were, because that part of the brain is not developed and we don't have consequences in place for them that are really real. And we don't have a place to place them so that they can have some real meaningful therapeutic intervention. So they manipulate the crap out of the system. And as they're manipulating the crap out of the system, next slide, please. Their brains haven't even properly developed. So they're constantly doing random reactionary stuff. And as they're constantly doing random reactionary stuff, we think we need to do therapy with them. We need to tell you that you need to do this and you need to do that. And kids are like, if I don't have rapport with you, if you don't trust me. When I was at the National Children's Center, I could be in session. Kids would tell me when somebody came outside the National Children's Center and sat on my car. They would say, Dr. Coco, man, these guys sitting out on your car. And then the other kids that were more aggressive on the spectrum, we used to have a term called Asperger's syndrome, which we no longer have, high-functioning people, they would say, you can't sit on Dr. Coco's car. You follow me? Didn't matter who they were, because they didn't have the interpersonal skills to know you shouldn't approach these thugs that are sitting on the hood of this car. But they would do that because they may be very fond of you. Now we're gonna go to the next slide and I'm going to start wrapping up so that we can have some comments, questions and answers because I'm sure a lot of things come up. That is a reminder of the significance of the environment. Now you see the impoverished environment. They always use rat models. My other friends that are neuroscientists, they work with rats. I had a latitude to work with brainwave research at Howard University. I wasn't interested in working with any rodents. You can't generalize what rats do in the lab in a controlled environment to what humans do. But big pharmaceutical companies love that because we can do a lot of research to find out what would do this with the animal, what would do that with the animal, and then we can dice up the animal's brain and see what's going on, right? But you can't do that with people. You can't even do that with macaque, chimpanzees, and you can't do that with monkeys because it's too expensive. But look at the environment. What do you think happens with a kid that grows up in an environment that King Tut Special Exhibit is in Northeast right now? It's about $18 to $25 a seat, right in Northeast Washington, D.C. I was there a couple of times. 90% of the people that I saw were my vanilla brothers and sisters, my melanin recessive siblings, and a few Asians. Right there in the heart of where you find a lot of melanin dominant people that were not in there because nobody communicated with them, as Tomas was alluding to, your interpersonal relationship, communicating with them. So they don't even know what's of value to them in the environment because no one told them. And no one expresses interest in them until they are either in trouble or they need somewhere to stay because they don't have a father in the home and something happened with the mother, meaning that the mother was trying to have all this on her own. So let me take you to this word and I'm going to stop so we can have a conversation. The thesis around a lot of mental health conditions for a lot of inner city people is learned helplessness. They don't think you're going to really help them. They think you're going to see them like our two colleagues, they were busy, they had to go. You know, sometimes we'll say, I was there, I did this and I left. Kids want more than that. They want you to interact with them. Even the people that profess to be your friends, they want you to interact with them. It's called cultural alignment. So let's go to the next slide. Go past the learn helplessness slide. Okay, we'll skip that one too. Go down to the next slide. See that? Let me tell you what a human is. I love to rub this in my class because my kids always want to know why I drop so much through biology on it. You see humans, hydrocolloidal, carbon-based, photobioelectromagnetic transducer, aerobic type, eumelanin dominant, or a mixed euphaomelanin, bipedal, cerebral-driven life form of organized colonies of bacteria, protoplasm, tellurium, surface rubber, hydrocolloidal. Your skin is the biggest organ in your body. Your skin will have you judged by people on a heartbeat. They have women worried about their skin once they've given birth to a child. They start getting concerned about saline. They have women get concerned about the wrinkles, and they'll sell you all kind of cosmetics for it. Then they will have people that are polarized, oftentimes by politicians and ignorance, with your skin tone. I was in France a few years ago, and I was also in Dubai, and I asked some of my vanilla colleagues, what do all vanilla brothers and sisters take back when they travel? You all know the answer? When they travel a lot, what do we always take back? Or what do we always seek out? What do they bring back home that they could put in their luggage? A tan. And the tan becomes something of conversation. Where did you go? Oh God, you have such a beautiful tan. True or false? Now process the value of a tan on my vanilla brothers and sisters, but process the inborn tan on a brother driving a 120 grand car in Southeast Washington, D.C. and cannot be identified as someone that plays in the NBA or an entertainer or a regular superstar athlete. You will get pulled just for driving the car. Are you following me? And so when you add that up and no one tells you that you're just only human, because the average person will tell you, you got white people, you got white people, and then they skip the colors and dump out of your Crayola box. All right. And they leave your Crayola box and they start talking about your ethnicity. Then they flip your ethnicity into your religious orientation. And then you get classified. Rather than you're just human. And a lot of our arguments and our money is lost right now because you have the LGBTQ plus community struggling with either coming out, and being marginalized or demonized because of what they have going on in their head and their heart is incongruent with what they look like. Are you following me? Rather than say you're just human. Our mental health model is sick. It needs to be tweaked. It needs to be revised. That's why my colleague, Dr. Youth, was telling you, we don't really have any tools for personality disorders because we tolerate personality disorders, and the level of tolerance is related to who you are, how much power you have. If Tomas and I were riding the metro and we wound up somewhere like, I don't know if it goes out to Bethesda, yes it does, Rockville. And if Tomas had on his swim shorts and I had on my swim short, and Tomas and I had on some flip-flops, they may say Tomas is just a little eccentric. But they may say, what's wrong with that black dude, man? Some shorts on the train out here in these flip-flops. And I'm not exaggerating. It's like, he may get a pass being eccentric, but people may wonder, does he have a mental health disorder? What's wrong with that dude? Are you following me? And that's what's wrong with our mental health intervention model. We need to train the people that are putting the diagnostic labels on you. So I'm going to stop so that we can actually engage in some comments and questions and remind you, move down 2 slides. I'm going to stop for this thing about water. Go again. Go again. You see that? All that relates to food deserts and water. Food deserts and water. If you don't properly hydrate, the only time you see information that documents hydrating is when people are in the Olympics or they're running marathons. You don't hear stories about kids really need to drink some good water. They need some good, healthy drinking water. The only time water comes up in the district or out in Maryland and Virginia is when we've had a serious rain and they'll say, let your water run for a while. You follow me? Let it run for a while. Because the average person that's on a fixed income, they're not able to go buy the kind of water. This is crazy water. This is some expensive water. You know, a gallon of this is like a gallon of petrol 5 years ago. So you have to take into consideration what's going to happen to people. And I'm not going to go into thing about food deserts. Maybe we'll have some questions and comments about it. But our mental health intervention model needs to be retooled. It needs to be more culturally aligned. And we need to have people that don't necessarily know how to engage the population, to invite people in, like Dr. Tomas and Tomas pointed out, not pro bono, but invite people in to do some training for folk to help people understand that they may have the degrees, the letters, and the licensure, but that doesn't mean you know how to connect. So I'm going to stop there because I'm hoping that people have some comments or some questions, and we can perhaps engage some things. All right. And while we're doing that, I want you to scroll through some slides because one I would like to be left up there. Just scroll. Keep going. Go again. I guess we can stop there. Leave it right there. Okay, so you guys have comments and questions for Dr. Ufik or myself? And you know, I have a lot of information, so I just, you don't want to like saturate you with it because, you know, like old people like, you think you're still in the classroom, but you're talking to peers and colleagues. That's what we're going to have: comments, questions, and answers. And they don't necessarily have to come from us and I. They may come from you.
But because you did give such a fantastic presentation with a lot of information in there, there was the slide that you did about cognitive abilities not quite being developed by 22 years of age.
25, 28.
Yeah, so the question I had is separate and apart from this, at the council, we've done some active intruder training. There was a narrative that came up about Columbine and some children that were just steps away from an exit that didn't leave because they were told by the teachers to stay under the table.
Mm-hmm.
So there was a cognitive connection there. I wondered if you could talk about, when we look at our youth programs and people we engage in expressing why, even at, you know, your early 20s, your response is still not wired for these other.
I would like, I wish I had, I do have a slide, but we'll have to go through to get it. You can scroll forward on my slides. I'll tell you when you get to it. You're going to get to a slide that is going to be somewhere between 33 and 34. Just keep scrolling. We'll get to it. I'll respond to it. The bottom line is, keep scrolling and I'll tell you when we're there. Keep going. But I think you were asking a question about why did kids respond a particular way in a particular situation where they stay there for a second. That's it. Back up. Go again forward. No, go, keep going. Keep scrolling up. Go again, again. One more time. You had to keep going because you had the brain there. Keep going. Go.
I think
So I think it's the
Okay, well, back up, because I have my screen in front of me. And that's not even the one, but okay, I can use that one, all right? Let me find that one for me here, okay? I can use that particular slide to share with you.
You want to show me which one? I'll find it.
Okay, this is the slide. See this slide?
Yeah.
Okay. What you see there, that relates to the brain developing and something called pruning. The brain has the ability to slough off those things that it doesn't really need. It's like you get too much. But what you just referenced when you're talking about age 22, but it's actually on the other side of 25 to 26. It's when the actual frontal lobes begin to develop. Children in situations of crises, and as you just referenced, I think you say Columbine?
That's at home.
Okay, and that was one of the original classic ones, right? I'll just give you a peekaboo. Actually, those two young guys that were involved in Columbine, they were coming off Prozac, all right? But no one wanted to disclose that. And usually psychiatrists, they don't have to tell you what medications a person is on and things like that. And Prozac, if you stop taking it abruptly, you have a rebound effect. I don't know if Thomas can expand on that, but I call it Jack in the Box phenomenon, because he made a comment about GABA-aminobutyric acid, GABA, which kind of lets you regulate things. But in a situation of stress like that, what happens just with people in general, if you hear a gunshot and a lot of things going on, you can stay there and we'll use that in a second. A lot of things are going on, you freeze. There is a region of the brain that's located beneath that arrow that you see to the left, far left over there, and where you see the red zone to the right, where you see the amygdala. That's something that they refer to as flight or fight response, right? But you also will note that on that same slide, you see where you don't have when the person is stressed, really stressed, it's almost like you can freeze when they go down. But if you have an authority figure in front of you that you recognize as trying to protect you, and those kids, let's just put them in the age bracket of like 14 to about 15 years of age, okay? Or 13 to about 15 years of age, all right? Those youngsters, that part of the brain hasn't developed yet. So they're not going to run around and defy authority when they hear a gunshot. Because one thing that you don't get in the news when there's a lot of gunshot rounds being discharged in an environment, gunpowder is in the air. The smell of gunpowder is in the air, okay? Also in the background, you hear moaning and groaning and you hear chaos. And anytime youngsters, like you throw a baby up in the air, you think the baby's trying to fly, the baby will extend his arms, and then when you catch the baby will smile, right? Because, it's like a game now. So you're giving them a rush and not a rush. So when something like that is going on, and those kids had marginal training because Columbine was one of the first when they had mass carnage, right? So they pretty much do what they are told to do. And they don't have the mindset to like judge the situation, because kids at that age, they may think they're firecrackers, or they may think that it's just something going on in general. They really won't know how to respond. So you need authorities to tell them how to respond. You follow me? Because that part of the brain is not working. If I were to turn these lights out of here, make it pitch black dark, and bring in a couple of Mastiff dogs, right? And I showed them to you before I brought them in, and then I turned the lights out and made them pitch black dark, and you heard them growling, you get anxious. You get really anxious. You'll be like, I don't believe Dr. Coco brought these dogs in here like this. You get anxious and you would cringe. And if you don't know anything about animals and humans, your body smell will change, but you would know that. Because the neurotransmitters in your body and your adrenal glands, your body's going to go through an entire chemical change. And if you're at that young level, this is not really working because you're stressed. I want to tell you some of the jokes I tell about people that really get stressed. And when they get stressed, people don't think straight when they get stressed. Some people have been socialized. They're like, I don't believe you're pulling a gun on me in broad daylight. But the average person that's been in a situation like that, they haven't been trained, they're like, yo, what you want? They automatically submit. But some people, depending upon how they're trained and socialized, particularly if they're over 35, they're like, there's a police car right over there. You follow me? But certain people that have been around violence, they know, hold up, yo, Slim, you got whatever it is you want. Got it. Feel me? But other people get real intellectual. When I showed you that slide about the frontal lobe developing over 35, that's where that arrogance comes in, that entitlement comes in. It's like, I don't believe you're doing this here. So that's a totally different situation. And it's worse than that when you're looking at young kids, all right? Because kids have an incredible keen sense of smell, and contrary to what does not make the news, kids will tell you, I remember the smell. Like when the kids got killed, there's a lot of kids, like 22 kids up around Yale on the East Coast, like around Connecticut. What was the name of that shooting?
The Sandy Hook shooting.
Sandy Hook, when they had all those kids to get killed, And when you get killed with certain types of rounds, because I used to do things on a military base, Quantico, those kind of rounds, they don't just do like the television, go through you. They tear your body up. And the velocity of those rounds can fuse bone mass, muscle mass, fascia, all at the same time. And because of the heat and velocity, there's a smell. That's why these kids would say, I don't want to talk about it. I don't remember it. And contrary to popular belief, when you get caught with rounds like that and you actually survive, that stuff that you see on television, they don't always take the round out. They leave it in there. You feel me? They don't just go in and extract, because it fragments. Feel me? So this part of the brain is not working. You want to talk to them? They may give you something in particular. Well, I was with my friend and I just felt wet all over, but I didn't know what it was. And then later on, I realized it was blood. And then they'll relive that, they go into shock. Now, I don't know if I really answered the question, because you kind of layered your question with Columbine and frontal lobe development. The fact of the matter is, that part of the brain that allows you to make meaningful decisions of judgment, it's not even beginning to mature until you're over the age of 26. I'm talking about the prefrontal cortex and the frontal lobes. Follow me? And there are people in here that will follow a fragrance or a smell, and they won't know why until they realize, like, my companion used to wear that fragrance. My granddad used to smoke this type of tobacco, and you'll smell it and it'll kindle all types of memories. And children have incredible sense of smell, all right? And they have this visual memory, and they have this kinesthetic memory. They will remember what they were doing. You follow me? But they may not be able to explain to you what's going on. Anybody have any more comments or questions?
Last one.
Yes, ma'am.
Thank you again, for either one of you. You talked about your ability to come in and work with teams and the dynamics of personality disorder, narcissism came up quite a bit. You talked about the power differential being something that you have to come in and train and get it to surface. I'm just interested in hearing, what do you do with that afterwards? Come in with the team and you stir that up to the surface. Like, what happens in environments that don't have accountability mechanisms, and we're identifying sources of problem behaviors that could be leaders, managers, supervisors?
Unfortunately, that's a really, really challenging dynamic to like navigate. However, again, you invite people in. It's not you per se. It's like several people would say, we think we need a training on the dynamics of how humans interact in this environment, how we interact, and we think it will like increase our level of functionality and allow us to do more work, blah, 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 blah. And see, what we're not dealing with, there's an aftermath of behavior that's a carryover from the pandemic. People were crowded around each other for a long time, and they were doing things online. And humans, interpersonal skills basically began to wane. You follow me? Because you were online. You meet a lot of people, you think they have a learning disability online, and they're talking with the kids, the dog, Lassie, everybody, because they didn't hit the mute button. And all other kinds of crap is going on, they didn't hit the mute button. And then they're on camera and they're just talking back and forth. They didn't hit the button to come on the mic, right? And then when you talk to them face to face, so you realize you did that, like, well, why didn't you tell me? So we try to tell you, like, because when you're home, you just set from here up, right? Down here, you may have on shower clogs, your sleeping pajamas and things like that, playing with Fifi or Lassie over in the corner and stuff like that, and telling your kids not to come by the screen, telling the cat not to come by, and the cat comes by like a sci-fi movie. All those things are going on. So when you get with people again, you've already in a household or setting where you don't want to be locked down with somebody that you thought you were in love with, but now you love and you tolerate, but you saw them every day and you were with them and you couldn't leave. You follow me? And then people tell you couldn't come to work unless you got this shot, that shot, that shot. Then you wound up with COVID. And again, you're like, damn, I got the shots, now I still got COVID. And you start tripping and you get into that mindset of like, that person that you're with is not being supported. And not only have they got on your last nerve, they've got on the last neuron on the nerve. You follow me? And so you're like, what am I going to do? And now you're back interacting with people. And you really don't want to be back quite just yet. You would like to have some of your work online, but they're telling you have to come in. And the people that are interacting with you, once you come in, they forgot all about the borderline and the personal skills that they had. Are you following? So you have to bring people in, like Tomas and myself and other people, say, can you guys come in? And remember, pro bono, you got to hook my boy up, right? When you come in, you definitely not going to get paid in America. The funny thing about the joke that I made about pro bono, in this country, if you do a lot of things people for free, they have a tendency to value it less. They don't think it's as important, rather than you paying them to come in and do it. I get hyped with this because I love kids. My axiom is I love working with children. All right, particularly prepubescent children and kids that are just going through puberty. But I don't particularly like working with adults. I love working with kids. You know why? Because kids will jack you. They will tell you that you look funny. My kids used to tell me all the time. They would say, "Man, you look like what's that cowboy named in Toy Story?" They would say, "Dr. Coco, I don't know what you are, man. You dress so funny sometimes." And they'll be talking about, but you interact with them. But see, they want to play with you, and they tell you they want to play with you. And if you don't play with them, they'll say, "Yeah, I'm mad with you. You won't even play with us today." But grown people, adults, they will play with you all the time. And when you catch them and say, "Stop playing with me, I'm grown," and they get angry. You're like, "I'm grown, don't play with me." And they're like, and they'll continue doing it. And you're like, "Don't play with me." Kids are like, "I want to play." Grown people will not admit to you that they want to play with you because they be playing with you, you know? Like, "I like what you have on." Then you catch them at the water cooler at the coffee spot. "I don't believe she wore that today. He got on too much cologne. Look at the trail of vapor following him down the hallway." Follow me? Because humans, we don't have the kind of filters, you understand? The filters actually get turned off when we're somebody we think we can trust. That's why, see, you can't be telling everybody your business at work. You feel me? But kids will just blabber out all your business. You know, and so you told me not to tell anybody, but I'm going to tell because I like him. They will disclose this. And if they don't know why they did it, you get that classic. "I don't know. Why you do that?" "I don't know." And sometimes you think they're lying, but a lot of times they don't know. I know some kids do carjacking in DC because I counsel some of the people that counsel the kids. "So why you do that?" "Man, I'm bored. I have nothing to do, man. You know, they closed the gym down, man. They turned where we used to play into a doggy park. You follow me? I ain't got nothing to do, man." So like, they ain't gonna do nothing but tell us like, you know, you go home and you go to court. Cause I'm 13 years old and I jacked 3 cars last month. So did you shoot anybody? "No, man, that was a plastic fake gun, man." And they get off on it. And then they pass these stories around back and forth. And then "You need to go to therapy 3 times a week." He's like, "I don't want to talk to you. You smell funny. You ain't even got a nice car. What can you help me with?" But let me calm down because like I say, I get pumped up. I think I'm in a classroom. I apologize for that. I had a lot of slides.
Any other questions, please?
I think she brings up a good point that we still, all of us are trying to address, but maybe the purpose is you do your own work, but it's like, if we do these trainings and these webinars, whether it's health or mindfulness, Strengths Finder, what is that accountability aspect afterwards to make sure? But I guess that might be the counter answering. Maybe we don't have the, the answers. We can't go coach our employers on make sure they follow protocols, but do you have any solutions of accountability post webinars, post trainings?
Sure. Well, I don't have a solution, but I do have maybe another angle to look at it. Even with things like personality disorders, which we've been talking about, when sometimes folks receive a diagnosis, they experience what we call normalizing. They realize, "Oh my gosh, I thought I was the only one. I'm really not the only one." And there's still a lot of power in being able to understand, wow, one's own patterns, how they could be dysfunctional. May not necessarily come with a solution. There may be a lot of difficulty therapeutically, but there's still a lot of therapeutic value in someone recognizing what they thought just themselves. They didn't understand why these patterns of relationship problems kept happening over and over again, giving it a label, helping them understand that there's actually a lot of people that are in the same situation. There are things they can do. That itself can be incredibly powerful. And one of the things about personality disorders is folks don't realize what's going on. Like living today might not know, or they might have a completely wrong perspective on it. But realizing it, going back to assessment, can actually go a little bit of the way. It's not a solution. I don't have that one for you, but it's something to think about maybe as well.
One follow-up thought after that as you bring it is, I was thinking about this also when you were talking about surfacing issues and going to therapy with somebody who is narcissistic and then they exit. And a lot of times we stay in therapy because we're with the narcissistic person. So does your training incorporate coping with people who have disorders or have power dynamics? You know that's not going to change about your leadership environment, but do you also work on the mental health of people who cannot necessarily escape situations where their work and their lives are influenced by people who won't get the help or don't get diagnosed, get treated.
Absolutely, a lot of therapy is very much that, they're in a situation or with somebody, they don't know how to cope, they don't understand what it is. And a lot of it's a lot of educating and coming up with solutions within whatever confines might exist. That's a lot of where therapy could be really beneficial.
That's why you bring in somebody like Tomas, or you may not want to bring me in because I'll put you on blast, right? But seriously, you actually need to have outside resources to address those things that you feel compromised trying to address on your own. And I always tell people it's unwise for you to point up the ladder at people that may have a lot more power over you, because sadly, they have all these guidelines and human resources, like you won't get any repercussions, you won't get this, but these people are sophisticated at what they do. They'll come back and tag you 90 days later for some minuscule crap, and you'll be on their list. That's why I say you don't tell everybody your business. So you bring in professionals and allow the professionals to flesh out those kinds of issues. And trust me, there are a lot of scenarios that you can use. If this wasn't like a couple of hour thing, you have interactive scenarios with people, and then you have the professionals to give you feedback on that. How could that have been done differently? And then you give them scenarios to act out. Because at the university, we have to take these little tests about sexual harassment. You can't even open the door for people to walk behind them in certain places because they're wondering. And if you say, wow, you look nice today, that could be viewed as inappropriate. You follow what I'm saying? And I have to tell my students, you can't hug me, all right? Now, why you can't? Because I'm an old dude and you are a young female student, or you're a non-binary guy, and you're saying, Dr. Coco, I like your hats, I like the way you smell. I'm like, but you can't hug me that long. He's like, why? I said, I'm cool with it, but these other people hey, I said, what's going on with that? Particularly, you're an A student, you're constantly doing your work. I have a colleague down in California. Every year he buys somebody a suit that has excelled in their class, a tailor-made suit. But it took him a long time to get the people at the university comfortable enough for him to do that, because they were wondering if there was some kind of innuendo or something going on to do that. Because in this society, we don't give things fluidly and spontaneously without expectations or hidden or shady agendas. So you bring people in to let people know it's okay to be people. I'm sure people get on my case because I'll say vanilla brothers and sisters, because they're like, well, I'm white. I'm like, you just don't have a good handle on neurobiology. You follow what I'm saying? But because that's what the media does. And the media will have you believing in stuff that doesn't even exist. You feel me? And then you'll be Instagramming stuff back and forth. H.G. Wells, War of the Worlds. I guarantee if you were to go out here now and see CNN and MSNBC News, and they just did a peekaboo special for 15 minutes a second. We just had a UFO, no longer UFO, landed by the Washington Monument. And all they have to do is feed it to the news twice. People be panicking. Their religious beliefs. What is the military going to do? Because you get into groupthink, which is ironically not thinking. And when you're not thinking, you need to get that cognitive behavioral therapy to let people make you realize that you aren't really thinking anymore. You're reacting to what everyone else is doing. And kids will blow all this stuff out the water because they're constantly testing their limits. You feel me? Because they're always evolving, doing crap that we said we wouldn't like, but they're doing it. You feel what I'm saying? So we have to be more present, because your mental health, contrary to popular belief, governs your physical health. All of you can hit the lottery today, but if you just gone to a chili festival and drank 64 ounces of your favorite beer, I guarantee you can have the answer nature's call before you go follow up on that ticket. You feel me? But you may say, no, I have to go. Well, no, your body's going to say otherwise. You follow me? I bet people have mental health issues, they don't even bring them up. They rush to work every day to get on time because they had to answer nature's calls in the morning and they didn't want to be late. And then they got to work and they got stressed out, and then they didn't answer nature's call. Then they got home and got stressed out, and now they're constipated, and that constipation has created a cortisol load on your brain, elevated your blood pressure, changed your cardiac rhythm, all right, and impact your ability to pay attention. And as that happen over a period of time, you're getting ill. That's why dis-ease is absence of ease. Disorder is things are out of order. You feel me? You guys don't have questions or comments. Comments would be great.
Dr. Tomas, you talked a little bit about the reciprocal cheating environment. Do you see that playing out in the workplace as well with relationships between?
Yeah, sure. So the question about the reciprocal gene environment at work. So absolutely, it really this idea that you might have a predisposition to being anxious or depressed, and then you're reinforcing the environment. So very much at work as well. You could be, for example, not going out for opportunities for advancement, or you could be deferring to a colleague, maybe it's a really bad influence, but you see them as, well, this person must have the answers. So you're just increasing your own anxiety, but also confirming your own biases. So it's really applicable very much at work as in other scenarios, for sure.
It's really outside of our committee. It's really about how we as the government look at our juvenile delinquents, I'll call them. Of those young people who are involved in a criminal activity. And we do know that some of it is because, as you stated, they don't have anything else to do, or they feel like, why not? How do we manage that feeling in these classrooms where we understand that there is a lot of disruption and chaos, preventing maybe a class from moving forward? Do you see us striving to separate out those problem kids and giving them a different kind of attention so that they can also have an opportunity to grow and thrive?
It's more in your arena.
Okay, so you guys are too young to know, but in this country, they used to have what they call grouping, right? You know, like you're in this group because you don't read as well. You're in that group because you don't do math as well. But like in Japan, they would put the students that were really bright around students that were reasonably bright. And they would have them engage in group assignments. So they would learn how to work as a team. And the youngster that you just mentioned, oftentimes you really need to have, I call it a head-heart check, right? Like I always do head-heart checks with my students when we're online or face-to-face. If a kid has come in and he slept with a sibling that wet the bed, and his mother was in the bathroom that morning, he couldn't properly clean himself, so he had smelled like urine when he got to school. So he may be isolated, angry, and not want to be around people because he knows he smells like urine, right? Also, if he is hungry, he may have a little bit too much, quote unquote, dignity of view of himself than to say to you that he's hungry. And he may want to eat what he has like a little snack discreetly because the other kids have things. It's up to us to better train our teachers and not overload our teachers and allow people to come in to speak when we have classrooms that are so dynamic that they appear to be always unruly. Because what we like is we like to put out of sight, out of mind. Asians and Africans and Latinos in particular, I'm not saying like, I'm talking about these people of color. They used to have a socialization protocol prior to the mid-80s. If somebody had a mental health problem, it was a stigma. You know, you'd be stuck around a corner or they minimize what you were doing. And those kids that come to school, they already know that they are not valued. They come from those environments. So you have to do something in that environment and make everyone feel included. But the challenge is oftentimes the teachers are almost burnt out. They're underpaid, they're using their personal resources to take care of these kids, and they don't have time. Follow me? So we need to bring in more resource people to have opportunities for those kids that have talents to actually shine. You follow me? Like if one kid is really obsessed with wanting to be a rap artist, you say, I want you to write 3 or 4 rhymes to me today and introduce them to something they don't have in their lexicon. I want you to turn this into a sonnet, and I don't want any curse words in it. All right? And I want you to write this for me. So you get them to do something that you incentivize them by recognizing what they really want to do. And let the other kids know that it's relevant in the class. Are you following me?
Yeah.
So that you can empower them. And the other kids won't look upon them like, man, every time you talk, man, you got that ebonic ghetto vernacular popping out your face. You don't even know how to talk. You know what I'm saying? I used to have people at university, they will write a paper for me. I'm like, yo, this is not a text message. I might talk and shoot the breeze with you, but you need to learn how to write. Okay? And if you send me some stuff from ChatGPT, I have a protocol built in to say, if you don't create the citation, then you get 20% demerits. You have to let them know up front. Because these chat platforms are so smart, you can't even tell. So you get sampling from the beginning. And kids that are shy, it's okay for you to let them know a little later. Like, I know you have a lot of salary. You haven't got to tell all the little kids. So what is it you like? And don't lock them into that Eurocentric mindset. What do you want to be when you grow up? I want to be a rapper. I want to be a basketball player. I want to be a surgeon. No, you must choose one. You convey to the child, okay, when you figure out the ones that you're most dedicated to, these are some things that you may want to focus on, come closer to realizing that goal. Are you following? So you have to engage them. You have to let them know that they have worth. I'm completely open and transparent. I'm always challenged by when we have these kind of events, where we have such a small number of people coming out. This city is in trouble, all right? I have one car, I don't even drive in the city at night, because I don't want some young buck to pull up on me to try to jack me, and then I don't mind him taking the car, but the point being, you cannot draw attention to yourself in the city and look like that you have a lot more than people that don't have, if you don't make them feel included. You understand? If somebody want to do the squeegee thing and clean your car, you know, like with that dirty water and stuff, if you don't want them to do it, just say, look, I got a couple of dollars for I don't need you to do it. You ain't got to do it, like give them money. You got a car that's off the chain that's like 120K. You can't be floating by these kids because they may throw something in the back of your car because you just, unfortunately, unbeknownst to you, disrespected them. You follow me? And then you gave them a reason to use you floating by to cathartic all that pent up anger that they have inside of them because they may not have a daddy at home. You feel me?
So how do we navigate the streets of DC feel disrespected?
That's a piece of work. That's a session. That's a round table. That's a piece of work. Because there's no like one size fit all. It's comprehensive. Feel me? Because you got people struggling with their identity based upon their phenotype, body type. You got people struggling with identity based upon their sexual identity. People struggling with their family dynamic around their religious orientation. Feel me? And then you got kids that are ironically not as confused you think they are. They're looking at adults. I had a kid that asked me, and he was only 11, not even one of my students in the school. Dr. Coco, I remember when you was up. I'm like, you 11 years old, you don't remember anything, bro. You remember? And then I'll tease them, they're like, my mom and dad are debating about who to vote for. I'm like, I think I'm my business. He said, what? Are both these people bad? I'm like, I can't get into that with you. You know, but the point being, they're looking at what's in the media. And they're like, you telling us to do all this nice stuff, and you got wars going on all over the planet, and you tell kids, like, don't fight, talk about it. And kids are looking at this stuff, they're like, you grown people doing some crazy stuff to each other. So it ain't nothing to them to jack your car or smack you in the back of the head with a 9mm because they didn't kill you. You understand what I'm saying? And then look at all these other people doing all this wild stuff, and they want to say, what's wrong with these adults? Because kids will ask you. Think about young kids, why do they do that? And you know you don't have an answer. So, you know, we got to be comprehensive and we got to be consistent. And y'all need to invite our people out or off from the universities, you feel me? And from the community.
Well, I think we have one more question and then we probably need to cut this off.
I just want to add follow up to Councilmember's question, and then we said about engaging with the youth, engagement and getting them interested in like actually figuring it out. How do you get the adult and the person to actually take on that with or to have that awareness to say, who
Say the adult, you mean the parent or the
person engagement?
That's an excellent question. So how do you get the adult engagement kids? Some of these kids will dish you right in your face, okay? And they'll tell you like, the expletives will drop out their mouths and say all kinds of things to you. You have to be the adult. Remember Michelle Obama used to say the thing, you have to take the higher ground. If you're not in touch with your own stress load, remember that thing about allostatic load? If you're not regulating your stress, and kids will read you. You can't come to them half-stepping and pretending to be something that you're not. You have to like say to them, like, hey, that was hard for me too. Feel me? And it can't be phony. You gotta let them know that, you know, I had to go through that. As a matter of fact, you really advanced compared to where I was when I was your age. You feel what I'm saying? You have to disclose, but you have to be authentic. Because kids will read you. And when they read you, you might get upset that they read you. So you have to be authentic. And you have to also exchange information. It's not like when people do diagnostic screening sometimes, I want to see you having any suicidal ideations. I need to get this done by this time. I only have X amount of sessions to get this data in and blah, 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 to make sure that you're not a threat to yourself and the community and so forth and so on. Like Tomas was saying a lot, you know, the tools that we use, they must be valid. They must be culturally aligned. And if they're not culturally aligned, you're going to miss the data that you need to get. So you just have to tune in. Like, you know, when you work with kids, you don't stand over them and talk to them. You have to get down to their level. You feel me? And you can't use a bunch of polysyllabic big words. Feel me? Find out what they like, what they would like to do. And it can't be a volley of, okay, would you like to do this? Have you ever thought about harming yourself? What about your brothers and sisters? You can't go down that list. You have to kick it. And I think one of the easiest ways to get a handle on kids' suicidal ideation is ask them what they think they're going to be doing next year, or what are they going to be doing when their birthday comes around, or when their holidays come around. What do you think you're going to be doing? And if these kids always have a bleak picture and they don't have anything that they want to do, then you can use that as a checkoff, like, you know, like soft suicidal ideations, or learned helplessness, passivity, or signs of depression, like when he said anhedonia, you know, no affect, no emotion. It's better for the kid to say, I don't like you. I just don't want to talk to you, rather than saying, these kids are so confrontational. If you and I grew up, and I'm a lot older than you all, if you grew up when you had to go to school and you were worried about somebody pulling out a 9mm, or somebody just showing up randomly from the community, shooting up people, as soon as you sat down and pulled out your lunch, worried about a gang jacking you for what they thought you had left, you feel me, and said, yeah, bring your mama here, we whip her behind too, blah, 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 and so forth and so on. And then you get bullied online, you have no sanctuary. And add to that if your old man is locked up. And if your mom is struggling with a lot of relationships, bringing a lot of people in the house. And complaining because she didn't have Pampers or Huggies or love to change the baby, and the baby's been in this diaper too long. Kids see that, and that tells them they are not valued. So they take risks.
Thank you both. Thank you. And if you don't mind, we're going to try to get you around in this government. I think it would be of great value for us to hear from you in other offices. Our specialist here, and she's going to make sure that happens, because I think she feels too that what you have shared with us is of great value for us to just know about our city and our community. So thank you again.
Thank you for coming.
And we're sorry this is pro bono, but we'll work on that. We'll work on that.
There are additional mental health first aid trainings. If you can't get a hold of DBH, there's some through the health insurance company budgets too. So reach out to me. And then there was one for children specifically, like there's